Hi, my name is Meredith McCrory. I'm currently a DNP student at Jacksonville State University. Tonight I'll be presenting about the Strong People program. This is for NU 712, which is Clinical Prevention and Population Health. The objectives of this presentation is to describe the older adult population, to describe the 3 levels of prevention. I'll introduce you to the Strong People program. I'll identify 2 Doctorate of Nursing practice competencies related and dependent to the implementation. I'll also identify data used to measure the outcomes. When you think of the older adult population, it's those individuals 65 years of age or older. According to Healthy People 2020, in 2014 there were almost 47 million individuals, and that is going to reach 98 million by 2060. According to the U.S. Census, there's a phenomenon called the Grey Tsunami that we've currently entered into. So 10,000 individuals per day enter into the older adult population, and the threshold of that will be 2030 when all boomers will be at least 65. When you think of such a huge population of people, you need to think of the chronic diseases associated with that population. So we're going to go through the top 10. So high blood pressure, high cholesterol, and arthritis. High blood pressure affects 47% of the older adult population. High cholesterol affects 47%. Arthritis, 31%. Other chronic diseases associated with the older adult population is coronary artery disease, diabetes, and chronic kidney disease. Diabetes affects 27% of that population. The last 4 we'll discuss is heart failure, depression, Alzheimer's disease, and chronic obstructive pulmonary disease, or COPD. Heart failure affects 14% of that population. And when you look at the statistical impact of those 10 chronic diseases, at least 80% have at least one of those conditions, and 68% have 2 or more. So if you think about the overall healthcare cost and how it's impacting us, that is great because that's a great number of people. But we're going to look at risk factors. We're going to look at those modifiable and non-modifiable. Modifiable is what we have control over. So it's blood pressure, weight, physical inactivity, smoking, diet. Those non-modifiable is stuff we can't control. It's our genetics, our gender, our age, which have a great impact on our overall health. And that leads to the type of prevention. There are 3 types of prevention within population health. There's primary, which encompasses health promotion and exposure reduction. So examples of that include tobacco prevention, exercise, healthy diet. Secondary prevention involves early detection and prompt treatment, and it's to slow that progression to that tertiary or those later stages. It's the preclinical or pre-symptomatic stage of the disease, and this includes any type of screening, so colorectal, your A1C, your fasting glucose. And then this leads to tertiary care, which are middle or late stages of disease. So it is our hope to alleviate the disability associated with that. So types of programs associated with tertiary care includes those cardiac rehabilitation programs. So people that have that coronary artery disease, diabetes, can go to these programs to help alleviate and restore function so they can remain active individuals and have a quality of life. The next thing we're going to discuss is the Strong People program. The Strong People program is primary prevention. It's an evidence-based community strength program that was developed by Dr. Miriam Nelson. It was originally called the Strong Women because her research examined the effects of strength training on bone density and other risk factors for osteoporosis. And she found that midlife and older women could safely improve bone density and muscle mass through progressive strength training. So her findings were published in 1994 within the Journal of the American Medical Association, and she began a whole book series, and she's focused on innovative research related to health, fitness, chronic disease, and community health. To implement this program, you have to have a multidisciplinary approach. Not only do you need DNP prepared nurses, but you need clinicians, nutritionists, exercise physiologists. You also need community leaders within the community that you're implementing this program. You need buy-in from them because they can help you with space for these exercise programs and educational programs that you're going to lead. They can also help with grant funding. You also need community volunteers because some individuals might have transportation needs that volunteers can assist with. The last thing definitely is we need consumers. We need people to come and have buy-in with these programs. So once this starts, the classes meet twice a week over a 12-week period. The benefits of this strength training program is to increase muscle mass and strength. By this, we're going to improve bone density and we're going to reduce related fractures associated with osteoporosis. So the benefits of this is also fall prevention. And if they fall, they're not going to get a hip fracture because they've been doing activities that can improve that bone density. By moving and becoming active, they're going to reduce their risk for diabetes, heart disease, depression, obesity. By being in a social environment, because these classes are between 12 and 15 individuals, they're going to have self-confidence. Their sleep is going to be better because they're becoming more active and not having a sedentary lifestyle. And their overall quality of life and their vitality is going to be increased. So what is our role as a DNP within this program? Well, we're the project leader and the developer. We're going to recruit community leaders and get buy-in from them to share the overall benefit of implementing this program. We're also going to recruit consumers to come and partake and participate in these programs, and we're also going to develop data tools to make sure that these programs are viable and have a positive impact on our population. The competencies related to the DNP is leadership. The DNP prepared nurse is going to be a leader, is going to develop the overall program, develop policies and procedures associated with it, have a collaboration with community leaders. Another thing that a competency that the DNP is going to excel in is business acumen. That includes the checks and balances, making sure that it's fiscally responsible, that this can have funding either through grant writing, buy-in from community leaders to use their facilities such as senior centers or parks. So you'll see the competencies related to that. The last thing that we're going to talk about is data measurement. So one of the perfect things that the American Heart Association developed was Life Simple 7. It's measurement of height, weight, the consumer's blood pressure, blood glucose, diet, activity, and self-reported smoking. So when a patient or a consumer comes in to these to the Strong People program, you'd get a base vitals, glucose, a questionnaire. Once the 12 weeks are over, you're going to take another sample, weight, blood pressure, glucose, diet, activity, self-reporting, and this program focuses on individual behavior change rather than environmental. So you're going to see differences in pre and post questionnaires and results. Most studies associated with the Strong People program saw a difference of 2 or more areas. So weight, diet, exercise, activity. In summary, the older adult population will make an impact on the overall healthcare system for years to come. Us investing in primary prevention of those modifiable risk factors that an individual can control, the healthcare system across the United States can see an impact on the number of patients seeking tertiary care. And this will increase the quality of life of the older adult population. And if you have any questions, please let me know. And here are my references. Thank you.